started. So welcome everyone to today's Addiction Research in Humans webinar, a 40-year career retrospective. Today's call is being recorded, and it is my pleasure to turn the call over to our first presenter. Please go ahead.
Yeah, hi everyone. This is Lisa Marsh, and I have the great privilege of introducing someone who's very familiar to all of you, Dr. Maxine Stitzer, and we're very excited that she's going to present today a presentation she had the opportunity to give at CPDD, the College on Problems of Drug Dependence Conference in this summer, where she received the 2019 Nathan B. Eddy Award. And this is a really prestigious award, as you all likely know, in memory of one of the pioneers in our field of substance use disorders established after Nathan B. Eddy's death. And it really is focused on acknowledging outstanding research efforts, excellence in research around advancing our knowledge in substance use disorders. And we all know Maxine embodies this, and huge congratulations on this award. Just briefly, this webinar today, she's going to give us an overview of her career and has really led pioneering work in advancing our understanding of opioid physical dependence, contributing to development of buprenorphine and to practice guidelines for methadone treatment of opioid dependence, as well as has really led pioneering work in developing effective contingency management interventions for behavioral treatments of substance use disorders. And she has been one of the original PIs in the CTN for the last 20 years from the very beginning, and as we all know, has made outstanding contributions to the CTN, including work around contingency management. So, Maxine, thank you so much for agreeing to kind of give an encore to your CPDD presentation here today to the full CTN Steering Committee. It's all yours.
All right. Thank you, Lisa, for that nice introduction. And I will tell you guys, hello in webinar land, by the way. This is the first time I've done a webinar, so I hope it goes well. And I'm actually broadcasting from the Friends Research Institute, which is my new affiliation since I retired from Johns Hopkins almost a year ago now. And it was indeed, of course, a great honor to receive the Nathan Eddy Award. And it gave me a chance to gather my thoughts about my career in addictions research. And so that's what we're going to be talking about today. Now, if you had been at the talk, you would have heard Eric Strain give a really wonderful introduction. But just to put the career in perspective, this is some of the education background. I don't know if you all know that I went to graduate school at the University of Michigan under Jim Woods, which was a fantastic way to begin a career. And then I did a little postdoctoral research with Jim McCurney in Boston, and in both of those settings was working with animals, with preclinical research, pigeons and monkeys up at Michigan, squirrel monkeys in Boston. But then in 1974, I kind of presented myself at Johns Hopkins and said that I was interested in translating what we had learned in the animal laboratory into the human situation, and doing research with humans. So this was a new enterprise that I started joining George and Roland. Now, human research was in its infancy back then, which I've characterized here as being in the Stone Age. Where things stood, addiction research in 1974. Well, okay, one thing is that tobacco cigarettes were killing people right and left, and the information, the link with lung cancer had really just only been widely established about 10 years earlier, and the research on nicotine as an addictive substance was just starting. Opiate addiction was endemic, particularly on the East Coast in the urban areas. And that had been since the turn of the century at least. And drug addiction, as far as treatment was concerned, was viewed as a moral failing, with residential communities like Synanon being the model of treatment. That is a place where you had to hit bottom and kind of grovel on the earth and then be resurrected as a new person. Now, there were some promising starts on human addiction research. One was at the Addiction Research Center in Lexington, Kentucky, where the federal prison was located. They called the narcotics farm, and people there were characterizing opioid dependence very nicely. And Don Jasinski was even there doing the original research on buprenorphine. Vince Dole, Marie Neiswander, and Mary Jean Creek had already invented methadone. They had repurposed the long-acting pain medication as a treatment for opioid use disorder, and that was beginning to take hold in the country. A very exciting development, though, was animal self-administration research that was spearheaded by Travis Thompson and Bob Schuster, was allowing the field to reconceptualize drug taking, not as a moral failing, but as a biologically reinforced behavior. And this was just opening up a whole new perspective on addiction research. There were some beginning attempts at controlled human research, such as the laboratory of Jack Mendelson and Nancy Mello in Boston. But really, so it wasn't exactly a blank slate, but there was certainly lots of research opportunity back then. When I got to the Behavioral Pharmacology Research Unit at Hopkins, I found this really rich array of resources that allowed me and my colleagues to all have a very successful career. We had a 14-bed, fully staffed residential research unit that is staffed by nurses 24/7, where substance users could be exposed to the drugs that they took outside on the street under medically controlled and monitored conditions. That was a wonderful resource. We had a small methadone maintenance research clinic that we made good use of, as you'll see later on. Pretty soon we had the T32 postdoctoral training program headed by George Bigelow, which provided some of the wonderful collaborative brain power and management skills that helped us to have a successful unit, inspiring colleagues, a collaborative team approach that was really a model for how to run a human research lab. And a rising NIH budget didn't hurt. There were some resources out there to fund our work. So 40 years later, it's actually more like 45 now, I'm gonna put my research perspective glasses on and look at it in the rearview mirror and touch on 3 different areas of research that I either led or was involved in at the BPRU, and you see what the 3 are there. Review some of the accomplishments with some comments on suggested future directions in each of these areas. So starting with opioid physical dependence. So we all know physical dependence is a key aspect of opioid pharmacology and a barrier for abuse-free pain medications. They were looking for the abuse-free pain medication when I was in graduate school, and the search continues today. But we wanted to know a lot about physical dependence, namely how does it develop, how long does it take, and what are the conditions for escalation? So this was basic research. It was inspired by work done by our wonderful colleague, Steve Holtzman, who in his animal studies had showed that opioid physical dependence actually begins with the very first exposure to an agonist medication or drug. Now, I wanted to take that work that Steve Holtzman had done and bring it into the human laboratory and see whether we could demonstrate acute physical dependence in humans. So the question was, what are the dosing and temporal parameters of opioid physical dependence development in humans? Now, we had a great tool to work with, which was naloxone, intramuscular naloxone, used as a challenge to precipitate or unmask subclinical symptoms of opioid withdrawal. And the basic strategy was to manipulate agonist and antagonist doses and interdose temporal window in order to answer the question about how physical dependence actually develops. So this is an example of the first 2 studies that we did. See, these are back in the 80s, late 80s. And here we have the morphine dose effect. So here we used varied the morphine dose using a 10 milligram naloxone challenge at 6 hours after the the single dose morphine exposure. So you see we have a dose-related increase in withdrawal symptom ratings. And from this study, we decided to use 18 milligrams of morphine for the subsequent studies. Now here in a separate study, we took 18 milligrams of morphine, single dose as a pre-treatment, waited 6 hours, and then gave the naloxone challenge at doses ranging from 0 to 30 milligrams. And you see 10 milligrams was sufficient to produce detectable and significant withdrawal. And that was the dose we adopted for future studies. So yes, we could demonstrate acute physical dependence at appropriate doses. And the symptoms that we saw were, some of them were the subjective reports of upset stomach, irritability, and so forth, but we did see some objective, tearing and yawning, which looked, helped to validate that this was actually an opioid withdrawal syndrome that we were viewing. So now the next step was to start varying the morphine naloxone interval. And on the left, we have the onset study. How long does it take after that single dose exposure until you can start seeing precipitated withdrawal? Here we varied the interval from 0 to 360 minutes. And you can see that the onset of this physical dependence effect could be detected by 45 minutes. So this was the time it took for the drug to be distributed after the IM injection and to produce whatever cellular and receptor changes are responsible for the physical dependence that we could precipitate with naloxone. Pretty remarkable, isn't it, to see these symptoms after 45 minutes after a single morphine dosing. Here's our offset study, varying the morphine naloxone interval from 6 to 72 hours. Now these open circles, that's placebo challenge, and the closed circles are the naloxone challenge. So you see some nice robust precipitated withdrawal when the interval is 6 and 12 hours. Nothing if the interval is 36 hours or longer. 24 was an interesting interval because you see some with precipitated withdrawal, but not as much as with the shorter intervals. And we utilized this 24-hour interval in some of the subsequent studies in order to look at escalation. What were the conditions for escalation of dependence? This is about the simplest study we could think of to look at dependence escalation with 1 versus 2 morphine pretreatments. So you're looking at subjective withdrawal symptoms, and this is a time course, post-naloxone time course. These circles are with the single 18 milligram morphine pretreatment, naloxone challenge 24 hours after that last morphine exposure. This is with 2 prior morphine pretreatments, the squares. We happen to have done this study in people with and without an opioid exposure history. There really wasn't a significant difference between the two, although it looks like those without a history were a bit more sensitive to the physical dependence effect, or at least had more variability. At any rate, we clearly demonstrated that we could see escalation because the intensity of symptoms is higher after the 2 pretreatments versus after the single exposure pretreatment. So we were able to demonstrate acute dependence. Oh, and let me just go back here. So, no, never mind, going forward. We were able to demonstrate quick onset and lingering offset, 24 hours, still a bit of effect observed with the parameters we used. Escalation observed when morphine interdose intervals were 24 hours or less, but not if they were greater than 24. And this is why some people can be chippers with heroin and other opioids. If they space their exposures far enough, they can do it without developing physical dependence. Now, it's interesting to note that since physical dependence changes last longer than agonist effects, users of opioid drugs may be unaware that there's a danger of escalating physical dependence, even with doses as widely spaced as once a day. Now, it's ironic that we stopped this line of research in light of the current opioid crisis, because it would be interesting to examine physical dependence development with an array of modern pain medications. And if I were to do that, I would want to look at exposure parameters that were needed not only for precipitated withdrawal with naloxone, but also the exposure parameters needed for people to feel spontaneous withdrawal symptoms without that naloxone challenge. I think information like that would be useful for patients who use narcotic pain medications, opioid medications, and for clinicians who prescribe those medications. Because physical dependence is something that begins right away, the first exposure, and then escalates depending on the doses and the temporal parameters. So that's opioid dependence and some of the lingering questions that would be interesting to take up now. Once physical dependence develops, medication-assisted treatment is the recommended course of action. Of course, we have both methadone and buprenorphine available now, but when we started our work at BPRU, there was only methadone. And providers were just getting used to it, and they were being pretty conservative with their dosing practices back there. So one of the first studies that we did in that little methadone research clinic was to explore optimal methadone dosing parameters. Let's see. So this was a study that was done with Eric Strain, someone very well known to you all. It was a 20-week study with a sample size of 60, and these people were randomly assigned to receive maintenance doses of 0, 20, or 50 milligrams methadone during this 20-week study. Why did we do 0 milligrams? You know, it turned out that there really had never been a placebo-controlled study of methadone, so we wanted to add that to the literature. And how did we do it? We did it by offering a 6-week taper at the beginning of the 20 weeks, followed by placebo medication. Now, mind you, everybody who came into this research clinic signed informed consent. They knew that research was being done, that they were volunteering for this. And of course, if they didn't want to volunteer, we gave them referrals to other methadone clinics. So we had people maintained on these 3 doses over 20 weeks, and let's see what happened. Put this back over here. Okay. First measure I'm going to show you is the treatment retention. It's clear that the higher doses produce better retention than lower doses. Retention was pretty poor with the 0 milligram dose. Maybe 20% of the people stayed around for the whole study. 20 milligrams was actually, retention was surprisingly good to me considering how low that dose is. 50 milligrams was the best, but even there we only had about 70% staying in treatment for the full 20 weeks. It's interesting to look at the withdrawal symptoms scores, ratings that we collected during the study. Of course, the people who remained in treatment to answer these questions were reporting withdrawal symptoms when they were maintained on placebo and, methadone. But the interesting thing here too is that the 20 milligram dose, as low as that is, was able to suppress withdrawal among those who stayed in treatment now, mind you, but it was suppressing withdrawal symptoms as well as the 50 milligram dose. So that's a pretty interesting observation. Here are the opioid positive urines. Again, dose related, with the 0 milligram having the highest level of positive urines, 20 milligrams next, and the best outcomes with 50, again, without complete suppression of opioid use on the outside. So what we wanted to do next was to look at some higher doses, since 50 milligrams was better than 20, but it could have been better. So we wanted to take the studies into the residential research setting to examine opioid blockade with even higher doses of methadone. This is a little hard. This is a study that was headed by Eric Donnie and Sharon Walsh. And what you're looking at, the data here is the answer to the question, how high are you? After the participants received challenges with heroin, during their maintenance on different doses of methadone. We actually got an IND for heroin so we could use the very drug that people would be using, giving to themselves in the natural environment. Now here's the methadone doses, and these were administered sequentially, so like first 30 milligrams, then the dose was bumped up to 60, then to 120. And each of these were kept in effect for 3 weeks, and during the final week, that's when we gave the heroin challenges to look at blockade. So now 0 milligrams of heroin, of course, you didn't see any subjective reports of feeling high. 10 milligrams of heroin, you see that the intensity of the heroin effect is inversely related to the dose of methadone. So on 30 milligrams, you see a nice boost of reports in how high are you. 60 milligrams was suppressed, and 120 was the highest dose of methadone, which pretty much completely suppressed the effects of this heroin challenge. And similar results when the heroin challenge was increased to 20 milligrams. So here we still see even a little bump under 120 milligrams of methadone, but it is within the range of placebo response. So careful parametric research supported the effectiveness of higher methadone doses. It was interesting that withdrawal suppression could be obtained with low doses as low as 20, and this allows such low doses to be used clinically, but doses of 100 milligrams or higher are needed to effectively block subjective opioid agonist effects. This wasn't totally new information. In fact, the developers of methadone, Dolan, Neiswander, and Creek, had used doses up around 80 and 100 milligrams. But as I said, the practitioners were being conservative at first and wanted to use lower doses. But dosing practices did change over time, with higher doses becoming standard. And we like to think that our research did a little something to move that along. You also should be aware of the fact that at BPRU, there was some very important seminal and pivotal research being done with development of buprenorphine, the safety and efficacy of buprenorphine. I definitely participated in all of this, but the leaders were Ed Johnson, George Bigelow, Sharon Walsh, and Eric Strain were the primary leaders of this line of work. And there was careful laboratory work characterizing the pharmacology of buprenorphine, as well as clinical trials showing the efficacy. And these studies were the pivotal studies that provided data leading to FDA approval of buprenorphine as a medication for opioid use disorder. I just threw in a slide from one of the early studies looking at buprenorphine dose-related blockade. This was really early. This was one of Warren Bickel's studies published in 1988. And again, this was maintenance on increasing doses of buprenorphine over time. In this case, though, the participants were outpatients. They were getting their buprenorphine outpatient, and then they came onto the residential unit for a few days at the end of stabilization on each dose. And here the challenge is hydromorphone rather than heroin. And cumulative dose of hydromorphone, you see the subjective effects, opioid adjective rating scale under the low maintenance dose. And as that buprenorphine dose gets higher and higher, you see a blockade of those subjective effects of the hydromorphone challenge. These Bs just mean that this dose, the effect of this dose is significantly different from the effect under 2 milligrams of buprenorphine. So just another example of the kind of careful parametric work that was done to support medication development of buprenorphine, in this case, buprenorphine. The culmination of this work was a book that was published and co-edited by Eric Strain and myself. It was published originally in 1998, I think, and then refurbished in 2006. And this collected our knowledge to date at that time. I think it probably has mainly historical interest now because it's a bit out of date, but it was a nice interim step in culminating the work that had been done at that time, which was substantial and very important. I actually looked this up, and you can still buy it on Amazon for $64.95, or you can just Google it and read it online. Now, what about lingering questions? This is one of my goals here, is to pose some lingering questions. Well, the lingering questions with opioid treatment medications, I think, are the very things that CTN is working on right now. Things like, how can treatment be made more accessible and more engaging through expanding capacity, reducing treatment burden, low threshold approaches, etc. And secondly, how can treatment be improved and the benefits extended over time? Maybe tweaking dosing parameters, looking at dropout reduction interventions, and new aftercare models. I'm sure all of you have got lots of ideas around these topics because you've just finished writing your competing continuations where you've written out all your new creative ideas around these kinds of questions. So now I'm going to move on to the final topic, which is our behavior therapy interventions. You know, opioids are not the only substance use problem that we deal with. And it seems, so opioid use medications are not the end of the story by any means. And in fact, the pendulum seems to swing between opioid and stimulant epidemics. And this was clearly the case in the 90s and early 2000s when the country was hit by a tremendous stimulant epidemic. Powder and crack cocaine were devastating the country, being used by rich and poor alike. And it was pretty bad. Now, this cocaine epidemic of the 90s fueled the need for effective behavioral treatments. Why? Because, of course, there's no medication that's been shown effective for treatment of stimulant use disorders. And this initiated what I call the heyday of behavior therapy treatment. There were two stars that emerged at that time who took some behavior therapy interventions that had been developed for other, like depression and so forth, and then repurposed them for use in addictions. And that was Bill Miller with his work in motivational interviewing, and Alan Marlatt with his work on cognitive behavior therapy. And the third prong in this triumvirate, the triumvirate of behavior therapies, was contingency management. Okay, and this is where George Bigelow and I came in as the pioneers of contingency management, and there we are, photoshopped into our pioneer outfits. And we actually got this award from the Association for Behavior Analysis a couple of years ago for translating basic research into clinical practice. So part 3, contingency management. Inspired by the behaviorism of B.F. Skinner and the recognition from animal self-administration that drug seeking is a biologically reinforced behavior, BPRU pioneered the application of contingency management to the clinical problem of drug addiction. The first thing we noted, and this was from the small methadone maintenance clinic, is that the patients, they may have had their heroin use under control, but some of them were using other extraneous drugs such as benzodiazepines and cocaine during their methadone treatment episode. Urinalysis testing, we recognized, was a really nifty objective marker of recent drug use versus abstinence. Covering the last few days, it was actually quite a good window in most cases. And our thought was that positive reinforcement, alternative positive reinforcement delivered in the presence of abstinence, delivered to people who are abstaining from their drugs, might be sufficiently powerful to counter the powerful drug reinforcers. So the protocol was that drug-negative urine set the occasion for delivery of positive alternative reinforcement. First thing we had to do was identify what would be reinforcing to our substance-using patients. And money was the first thing, universal reinforcer for people. Everybody likes money. The other was the methadone take-home privilege, single-day methadone take-home. So that is, if a negative urine was delivered on Monday, the patient could have a single-day take-home for Tuesday, and so forth, single day. And that was a nice one to use because it was desirable. It didn't lose its potency over time. It was like a discrete thing that could be handed out time and again without losing potency, and safe as well, because if by any chance the patient went out and used drugs on the day they had the take home, it would be self-limiting because they would come with a positive urine the next day and not earn any more take homes. So that was actually quite a nice reinforcer. Now, I like to show this study when I talk about contingency management. It was one of the very first studies that we ever published, and it was done with a handful of methadone patients who were abusing benzodiazepines. So you're looking at the mean percent of negative urines delivered first prior to the intervention, and that, of course, percent negative urines was very low because we handpicked these people. During the intervention, you get this substantial and dramatic increase, up over 50% negative urines delivered, and then post-treatment, a drop again back to pre-treatment levels. So what happened during this time, during this intervention time? Well, it was 12 weeks and urine testing on Monday, Wednesday, Friday, and if the urine was negative for benzodiazepines, the patient could choose either $10 in cash or a single day take home for the following day. And when you see 50% response rate here, that doesn't mean that everybody delivered half their urines negative in a sporadic fashion. No, what it means is that half the people bought into the program, stopped using their drugs, and continued and sustained long periods of abstinence from benzodiazepines during the study. And the reason I like this study is that the results are so consistent with so many studies that have followed, both in the extent and pattern of response to the introduction of a contingency management abstinence incentive therapy. So at BPRU, we kept on doing this work. We did small proof of concept studies, varying the drug targets, the reinforcers, the schedule parameters, but a lot of the action was taking place outside of the BPRU. And that was with these two individuals. Steve Higgins, who was a postdoc in our lab and went off to the University of Vermont and started applying his fantastic behavior analytic background, behavior analysis training he had in Kansas, to develop the voucher reinforcement program where points with cash value were used as rewards each time the patient delivered a negative urine. And then Nancy Petry, who was not a student of ours but had been in Steve's lab, took it one step further and developed the intermittent reinforcement schedule with ticket draws and prizes that made the procedures attractive, kind of fun, a little more fun, attractive to clinicians, and the potential to reduce the cost. We brought voucher reinforcement back into BPRU, and this was one of the studies that Ken Silverman headed. This was methadone patients who were cocaine users. Percent negative urines is what you're seeing here. Very low percent negative urines during baseline. These are hand-picked people because they've been using cocaine with no intervention, no treatment control, continued use of cocaine, very few negative urines throughout this lengthy 52-week study. This was a long one. This is take-homes only, and those worked really well for a while. For some reason, they kind of fell off toward the end. I will never know why. But when voucher reinforcement was added, you see this sustained rate of negative urines up around 60%. So that was, remember the 50% we saw with the benzos, here it's 60. That's very typical outcome. 60% of the people buying into the program producing lengthy periods of abstinence from, in this case, cocaine. Looking back at the CM research at BPRU, I think the main contribution that we made was in the initial pioneering work of applying the principles, in persisting with the research over time, and importantly, in training future CM researchers. And I've just shown some of the many people who came through the lab and then went on to do some wonderful research of their own with contingency management as well as other types of research. But we really did work with a lot of great people and sent them on their way to carry the torch with contingency management. Now, something else happened right around 1999 to 2000. Guess what? This is when the Clinical Trials Network was formed to study treatment effectiveness in multiple real-world settings nationwide. Recognized that most of the early addiction treatment studies were conducted in small research clinics like the one we had at BPRU. But with the advent of the Clinical Trials Network, it was time to test research-based treatments in community clinics in order to bridge that gap between research and practice. One of the first things that happened way back in the early 2000s is that I had the immense and joyful opportunity to work with, Nancy Petry. I always get choked up when I talk about Nancy because we lost her way too early in her wonderfully successful career. It was a joy to work with Nancy on CTN 05 and 06. It was the first large multi-site study conducted in community treatment programs, and of contingent abstinence incentives, and we did use Nancy's fishbowl or prize draw method. It was actually 2 studies, parallel studies using the same protocol with stimulant users, either enrolled in methadone maintenance clinics or another group that were enrolled in drug-free counseling clinics. The target was stimulants, primarily cocaine, and the randomized design, 2-group design with usual care with and without the prize draw incentives. Here are the results from the 05 study. This is the study in the drug-free counseling treatment programs, where the random assignment was to incentive versus control conditions. And I'm showing you improvements here in retention. These were statistically significant improvements in retention during treatment. But we didn't have any effects on drug use. Why? Because in these community treatment programs, 90 to 100% of the urine submitted in both groups were stimulant-free, so there was a ceiling effect. We might say that the improvement in retention is a surrogate for relapse prevention, but it's an imperfect surrogate because people leave treatment for lots of reasons, relapse to drug use just being one of them. At any rate, the study was successful in demonstrating an improvement in outcome with the contingent abstinence incentive. The other parallel study done in the methadone clinic the results were really interesting because they were so similar to what we were used to seeing in the small research clinic studies. Here we have usual care control condition delivering about 40% negative urines throughout the 12-week study, with a much better percentage, up around 60% negative urines delivered in the group with the contingent incentives. And really the only difference between this and the smaller studies is that this rate of negative urines in the control condition was higher than we're used to seeing. So the initial CTN studies provided evidence for effectiveness of contingency management abstinence incentives in real-world settings. And CTN has gone on to do some other research with contingency management. 044 is probably the best example. This was the web-based therapeutic education system study. And there were two differences here from the prior study that are of note. First of all, the participants were all comers enrolling at community substance use treatment counseling programs. These are drug-free clinics. They're not delivering opioid medications, but these are all comers, so they're entering with a variety of primary drug problems. They're not handpicked because they're demonstrating use of a substance during treatment. The other difference is that the treatment, this web-based treatment incorporates as well CBT modules as well as abstinence incentives. The modules are self-administered by patients, urine testing was conducted at the clinic, and the design was random assignment to usual care with or without the web-based treatment program. Effectiveness was shown in this study. Primarily, though, for those with active drug use at treatment entry, this is the published findings. And this graph, if you're not familiar with it, the participants were divided into those who had a positive, who demonstrated abstinence at the beginning of treatment by delivering a negative urine, or demonstrated ongoing drug use by delivering a urine that was positive for some substance. And the interesting thing here is that the effect of the intervention was seen primarily in those who were actively using drugs at treatment entry. So the contingent incentive was effective at kickstarting abstinence in those who were actively using and struggling with trying to become abstinent. In this particular study, those who came in having already stopped their drug use had pretty good outcomes overall, no effect of the intervention, which is a little disappointing because there really was some room for improvement here. So it's interesting that the effectiveness did not depend on the type of drug being used, but rather on the presence or absence of active drug use at treatment entry. And this is consistent with other observations, and I think it's really important clinically because it has implications for targeted treatment delivery strategies. The fact is that most of the money that you're going to spend in a CM program is going to be given to these people here who have good prognosis anyway and questionable whether the abstinence incentives are providing any benefit. The people who do benefit are the ones who are actively using and struggling with becoming abstinence. So, personalized or individualized, this is a consideration for personalized or individualized treatment. CTN also did the 49 study in which incentives were used to promote healthcare behaviors. And in this one, we showed that this is with patient navigation, with or without contingency management. Incentives were associated with substantial increases in targeted healthcare behaviors. You see some of the results here. Navigation visits attended were remarkably better. There were only 11 possible sessions, and the median was 11 in those who could earn some money for attending their navigator visits, versus 7 in the patient navigation arm without the incentives. More doctor visits and more people entering substance use treatment. So now let's put contingency management in perspective for a minute. I think it's clear that addiction researchers like contingency management. There's a huge body of research that's been done demonstrating efficacy for every type of substance abuse, for HIV medication adherence, and for appointment attendance, like what I just showed you in the HOPE study. So researchers like it and they do a lot of work with it. But CM is less widely liked and used by treatment providers in clinical practice, despite its status as an evidence-based treatment. Some of this has to do with the convenience of delivery, some to do with the familiarity of the model that's being used, and some to do with the cost or perceived inability to find financial support for the prizes and incentive rewards. However, there have been some new developments lately that I want to make sure you know about that are really changing the whole scenario for contingency management delivery and making, improving the outlook for delivery. One is remote sample testing technology that has revolutionized CM delivery. It's now possible for participants to to do testing at home. They take home a carbon monoxide meter, an alcohol breathalyzer, or a saliva test kit. They can perform tests on themselves at home, video record it on a video tape or smartphone, and send those videos in for verification, and then reward payments can actually be downloaded automatically on debit cards. So using this kind of technology, 2 different smartphone apps have been developed for convenient technology-supported delivery of contingency management. One is called Reset, and it actually is deploying the web-based program, the Therapeutic Education System, that was tested in CTN in that study that I just showed you. Another one that you may not have heard about is called Dynamic Care Rewards. This utilizes all these new technologies, patient self-testing and remote delivery. It has not been as widely researched as has Reset. And because of the nice evidence base, research base behind Reset, FDA has recently authorized or recognized this as a digital therapeutic intervention for substance use disorder. So this is a pretty interesting development. So CTN seems well suited for integration with 21st century technology. The groundwork has been laid for expanded implementation, and the hope is that payment for the interventions that include contingency management and abstinence incentives may be forthcoming from insurance companies, employers, and treatment system providers. So I think there's a bright outlook for further adoption of contingency management. Like with the other areas that I've covered, there's some lingering questions that can be raised. I think there are some very important questions. One is whether CM is helpful for relapse prevention and those who stop use on their own, whether they do it inside or outside of treatment. You've seen some evidence from the 44 study that CM really wasn't helpful for people who had already stopped their drug use. I think we need some more research on that particular question. Relatedly, how long should CM be sustained? Even if the person was enticed into stopping through use of incentives, how long should it be sustained? We know that the chance of long-term abstinence is directly related to the duration of prior abstinence. Some elegant work by Steve Higgins showed that. To me, that suggests the possibility of individualized durations, that this may be optimal so that keeping CM in place for a period of time until the individual reaches a milestone of abstinence, such as 6 months or 1 year, rather than cutting it off at an arbitrary time. And then the final question is, how can benefits be sustained beyond the time that CM is withdrawn? And here we need to look at the role of CBT skills, lifestyle change, and additional supports that may be needed, such as recovery coaching. So the career perspective, I've taken us from the Stone Age to the phone app age. Stone Age to the phone age. We've come a long way for sure. Let me go back to this. We've come a long way, and that's for sure. But science never rests on its findings or its laurels. So I've also been able to raise a number of questions that I've put out there for consideration by you all who are on this webinar, as well as others. Some of these questions are best answered in large clinical trials like the CTN. Others are best answered in smaller scale efforts. But the point is that there's still a lot of questions out there to be answered. So gosh, this is great. I've actually finished with some time to spare for questions and comments. It was certainly a great honor to receive the Eddy Award, which came with the opportunity to develop this talk about addiction, human addiction research over the decades. I'm very grateful to all of those who supported the nomination, and more importantly, to those who helped to do all the work that went into the research that I've reviewed. And I've just included, as I did in my Eddy talk, a couple of random photos just to show you some of the people, some of the wonderful colleagues that I worked with over the years. I'm sure you recognize Eric Strain, Kenzie Preston, Jack Henningfield, George Rowland, and this is Annie Umbricht. And then there was the army of postdoctoral fellows, of which this is a very small sample. But these were the people. Here's Eric Donnie, Mary Mincer, Andre Jones, Els Houtsmuller, and there were so many more. This is the brain power and the person power that kept all the research going, while I and my husband were sometimes off in the Himalayas and other mountain ranges doing our international trekking. So it's been a wonderful 44 years, and as I said, we've got some time for comments and questions.
Wonderful. Thank you so much. If you have a question today, feel free to unmute your line. On the Zoom platform, you will see a button that allows you to unmute your microphone. If you'll just state your name and your question, you may go ahead.
Maxine, this is
Hi.
Dennis. Hi, this is Dennis Donovan. I can't resist the pun, as you well know, but it really has been a very reinforcing career. And I really want to pat you on the back for that.
Thank you, Dennis. It was a lot of work, but boy, those years flew by really fast.
Maxine, can you hear me?
Yes.
Hi, it's Lisa Marsh again. I just wanted to thank you so much for your presentation. I wish there was a way to do a virtual applause on a webinar because this was outstanding and we have such a great group on this call. Just your career has just been and continues to be just so amazing and impressive, and the contributions you've made have been so impactful. And, personally, I was first introduced to research in substance use disorders at BPRU at Hopkins. That was my first exposure to it. And personally, you've been such a huge role model to me, and I had the opportunity also to work with many of your trainees that have really impacted my career. So I just wanted to thank you so much for this really remarkable presentation and just all you've done in these 45 years and continue to do. And it's just an honor to have the chance to work with you as a colleague in the CTN. Thank you so much.
Sure. Thank you. When were you at BPRU, Lisa?
Do others have comments or questions? Just be sure to unmute yourself on Zoom.
Doesn't anybody have a question about the research?
Hello, this is Betty Tai. Can you all hear me now?
Yes, Betty, hi.
Hi, sorry, I was having problem with the audio early on, so I couldn't speak up and I couldn't hear much. But I just want to say, how wonderful your career was, not just to the CTN, but to the entire field. And I have to tell you that from all I hear, that you are the kindest, most generous mentor one can have. You literally helped many, many people, help them to launch their career. And I think you only showed picture of a few, but I do know a list of other names. So when I was at the CPDD, I heard your talk. I was so impressed. And I was so tearful, and I came back. I said, many people did not go to CPDD. They need to hear this from the CTN. And it only took this long to finally to hear your talk, but you know, the feeling is still the same. And I think, you know, one of the CTM future endeavor is really to start it, cultivate and helping the next generation researchers in drug abuse. And I hope you can continue to help to teach us how to mentor the next generation, how to, you know, foster their career, and how to inspire them to be independent investigators in the near future. And most importantly, I think if you can continue to teach everyone how to write a good grant, because you are very well known among the community that your grantsmanship is just incredible. And I'm so grateful that you spend the time and having this talk with us. And I'm sure everyone would enjoy this very much. And I hope, although you said you are retired, but I hear your voice and your talk, I don't think you can give this all up very easily. We want to continue to see you and continue to hear from you. And please come join our gatherings each time. And the best luck to you. And next time, I hope we can have a chance to see how you dance. It was just incredible. Thank you so much. I couldn't say enough thank you.
Thank you for the invitation to do this, Betty.
So Maxine, we have 3 more minutes left, and there's a comment here in the chat from Kimberly Page that she has one question for you. Kimberly, go ahead.
Hi, Maxine. I really enjoyed this talk, and not being an addiction specialist, it was really enlightening to hear the history and the progress. What do you think needs to happen to make progress get into clinical practice quicker? There were various instances where you talked about that, low doses of methadone, providers being less willing to adopt research-based evidence. What do you think needs to happen, or what are some of your ideas about how to shorten that interval or to facilitate that adoption?
Well, that's a big question, and I'll bet other people on the call have ideas too. You know, the Clinical Trials Network, that was one of its first raisons d'etre, was to introduce evidence-based practices into the community programs in order to, you know, to create that kind of bridge. And once they had seen how the intervention worked in their particular program, then they would be more likely to adopt it. I mean, the problem is that clinicians have their own set of priorities and their own set of reinforcers and their own set of rules and structures that aren't always compatible with adopting new practices. But the good news, I think, is that practitioners are always interested in improving. They really want to improve their the treatment that they deliver. So, you know, I don't really know the answer, but I think that CTN is beginning to explore some of the ways, well, not just CTN, but other researchers as well, in implementation science, beginning to explore that question. How do you get effective interventions from the research laboratory into clinical practice? And those ways like coaching, like mentoring and coaching through you know, technology-based Skyping and so forth, doctors talking to each other, addiction specialists talking to non-specialists and trying to, so I mean, that's one way, but there are a lot of different ways. So I think one of the answers is you do it through implementation science research.
Thank you.
Maxine, I know we only have 1 minute left. There is one more question, so for whatever subset of folks can stay on, would you take one more question?
Sure.
Okay, go ahead, Judith. Thanks.
Hi, thank you for a wonderful presentation. So my name is Judith Feinberg. I'm in West Virginia, a place that's got an overwhelming amount of substance use disorder and is very poor on resources, and especially because we're seeing a lot of methamphetamine now on top of or supplanting opioid use. I was really interested in your conclusions about contingency management. And I'm wondering what do you, because sustainability and resources for rewards that cost money is going to be problematic. But you made a statement about the possibility of third-party payment. So I'm wondering, are you thinking that could be insurers?
Yes, I am, exactly, because we've got, CM is an evidence-based practice, and the cost barrier is a very frustrating one because, all interventions cost money.
Right. So I guess what I'm thinking is so then that would turn out really to be a subject for, discussion and political pressure rather than from a research approach.
Yes, no, I think so. That's right. I think research is only one avenue and one prong in the attack of adopting better practices or of changing the whole public health scenario. Yeah, so the fact of this one digital therapeutic being recognized by FDA, it's just a nice little foot in the door. It doesn't guarantee anything, but it gives some ammunition in going to insurers, employers, and so forth, and giving them, a pitch to. And there have been some inroads where insurers are beginning to at least experiment with paying, including, contingency management as part of the bundle of therapies that are delivered to substance users.
And that's great. I mean, I think that opens up some avenues of approach. Thank you.
So we probably should wrap up, Maxine, since we're a couple minutes over time, but just a quick, again, thank you so much for all of your pioneering and important work that you've done and continue to do. And thank you so much for sharing this story with us today and your journey through this. Thank you. Thanks all for joining. Have a great holiday.
Yes, great holiday all. Bye.